Good morning. My name is Sarah Weiner, Program Manager of Education and Practice at the Association of Schools and Programs of Public Health. Thank you for joining us for today's ASPPH Presents webinar, The Triple Aim of Health Equity. Today's webinar will be 1 hour in length. We will begin with an introduction of our presenter, followed by his presentation, and ending with a question and answer period. This webinar is part of the 2017 ASPPH Presents monthly series. The webinar is being recorded and it will be available on the ASPPH website in the archived webinar section soon. Additionally, this webinar has been approved for 1 hour of CPH continuing education credit. A few housekeeping items of note. While you are in listen-only mode and your lines have been muted, we encourage you to ask questions throughout the presentation by using the question box. We will address your questions at the end of the presentation. We are pleased to welcome Dr. Lavon Ortega, Lead for Academic Partnerships to Improve Health in the Division of Scientific Education and Professional Development and the Centers for Surveillance, Epidemiology, and Laboratory Services at the Centers for Disease Control and Prevention, to introduce today's speaker, Dr. Edward Ehlinger. Thank you, Lavon.
Thank you, Sarah. Dr. Edward Ehlinger is Minnesota's Commissioner of Health. As Commissioner, Dr. Ehlinger is responsible for directing the work of the Minnesota Department of Health, the state's lead public health agency. Prior to his appointment as Health Commissioner by Minnesota Governor Mark Dayton in January of 2011, Dr. Ehlinger was Director and Chief Health Officer at Boynton Health Service at the University of Minnesota. Dr. Ehlinger served in the National Health Service Corps from 1973 to 1975, and from 1980 to 1995, he served as Director of Personnel Health Services for the Minneapolis Health Department. Dr. Ehlinger's commitment to training and educating the future workforce is evident in his many collaborations with academia. He is an adjunct professor in the Division of Epidemiology and Community Health at the University of Minnesota School of Public Health. Dr. Ehlinger is a member of the leadership team of the Big Ten Academic Alliance's Health Equity Initiative, which brings together member universities and their state health departments to address the social determinants of health and bolster health equity. For the past 3 years, Dr. Ehlinger has addressed incoming medical students at the University of Minnesota School of Medicine about population health, health equity, and their influence on an individual's health status and outcomes. Dr. Ehlinger has also been called upon to provide commencement and keynote addresses at the University of Minnesota School of Spirituality and Healing, the Center for Bioethics, and the Community of Health Service Directors at the Big Ten schools, to name a few. Dr. Ehlinger is board certified in internal medicine and pediatrics and has a master's degree in public health. He was a Robert Wood Johnson Clinical Scholar and a Bush Fellow. He is past president of the Association of State and Territorial Health Officials, the Minnesota Public Health Association, the Twin Cities Medical Society, and the North Central College Health Association. And at this point, it gives me pleasure to turn it over to Dr. Ehlinger.
Good morning, everyone, and thanks for being on this this webinar. This is my week to deal with academia, I guess. I talked to the provosts of all of the Big Ten schools yesterday, and we'll be talking to the health service directors from the various schools of the Big Ten next week. So we'll see. Now I got to move the slide here, and for some reason it is not. There we go. All right. So I'm going to be talking about advancing health equity and optimal health for all. And it's good that we're doing this on today, which is the birthday of Virginia Apgar. Certainly as a pediatrician, used the Apgar score quite frequently in my training. And for those of you who don't know, Virginia Apgar is an anesthesiologist who developed this mechanism of assessing an infant's health and well-being shortly after birth. And recently, Medscape had a list of most influential physicians, and she was ranked number 45 as one of the most influential physicians. And so the scale that she put together, talked about appearance and pulse and grimace and activity with babies, and they at a 0 to 2 score at 1 minute and 5 minutes. And so when I was thinking about this presentation, I thought, we should do an Apgar score for our country. We're now about the 5th month into a new administration. And I think some of the things that Dr. Apgar put on the assessment scale would be appropriate. Our appearance. How are we looking to our citizens and to the rest of the world? Are people excited about the vision of our future? What's the mood of the country? Are people working together? And is democracy alive and breathing? And I won't answer, and I won't give us a score at this 5-month period, but I'll let you do that on your own. But I do think one of the quotations from Virginia Apgar said, nobody, but nobody is going to stop breathing on me, meaning she was not going to let any infant die. And so I think part of our job is to make sure that no one stops doing what really needs to happen to keep all of our public health work and our democracy work alive and functioning, because that's what's really going to keep us healthy. So with that as a little background, I think let's look historically. We have done quite well. We have done a great deal over the last 109 years. Looking at this slide, we've added 31 years of life expectancy from 1900 to 2009. And most of that, you can see the jagged line at the first part, really because it was infectious diseases and industrial occupational injuries that did it. But this slide on the left shows the drop in infant mortality from 1900 or 1915 thereabouts to 1995. Dramatic change in infant mortality, dropped dramatically. And then the slide on the right, the maternal mortality dropped precipitously starting in 1920. I don't think that it is by happenstance or just accidentally that women got the right to vote in 1920 and maternal deaths started to drop immediately after that, but it's had a huge impact. So you can see that if you compare sort of life expectancy and how people died and when they died at these 3 big cohorts, the blue line is the people who were born in the early 1900s. The yellow line is people who were born in the middle of the 19th century, or the 20th century, excuse me. And the red line is people who were born in 2010. And so you can see that we've made some huge differences, particularly in early life. In early 1900s, 20% of the people died by the age of 5 out of that birth cohort. Today, we don't get to 20% of the birth cohort dying until age 70. So that is where the big increase has been in our increasing life expectancy. And I'll get to that in a little bit, because you can see that most of that these are the leading causes of death in 1900 and 2010. Certainly infectious diseases in the green were the biggest killer back in the early 1900s and have dropped to almost imperceptible levels in 2010. The other big area was accidents, the brown bar down at the bottom, where there were 72 deaths per 100,000 people. It's now down to 38, cut that in half. Certainly heart disease has increased a little bit, and cancer has increased dramatically. So the improvements that we've had are really in some of the things where we've had infectious diseases and occupational injuries. And we can't go without saying, because people say out of that 31 years of life expectancy improvement, 25 or 26 of those years have been because of public health achievements. And these are the real great public health achievements of the 20th century, certainly immunizations and motor vehicle safety, workplace safety, control of infectious diseases, tobacco, fluoridation, family planning, healthy mothers and babies. All of those have really been important in improving our life expectancy over the last 100 years. But what you can see, that little red line should be a little bit higher. It was sort of identifying the fact that we had major improvements and rapid improvements in life expectancy from 1900 to 1950, but when we turned over to having chronic diseases as leading causes of death, our improvement really started to slow. And so we're not making the same kind of rapid progress in the last 50 years than we did in the prior 50 years. And what's really disturbing is that actually in 2015, our life expectancy actually fell for the first time since the early 1990s. I hope this is not a trend, but it says that, you know, we can see that line, it started to slow a little bit in terms of increasing life expectancy, and certainly now in 2015 actually declined. Small amount, but when you're dealing with a population, that's a huge impact, and we'll see what the data show, but it is an ominous sign for our health. And so from my perspective, what I'll be talking about is sort of how equity fits into this. I believe this is looking at infant mortality, comparing the United States to the developed countries, the OECD countries, from 1960 to 2010. And you can see that the United States, which is in blue, really tracked, it was better than most other OECD countries, and tracked really parallel with them until about 1980 or so, when we started to fall behind all of the other countries. We were 12th ranking in infant mortality in 1960, and in 2015 we are now 38th. It all depends on who's doing the counting, but we're, you know, between 30 and 38th in terms of our overall infant mortality rank in the world. And I don't think it's coincidental that our decline in 1980, or where we actually, our infant mortality started to fall behind everybody else, is about the same time that our disparities in infant deaths also started to increase. This slide shows the black-white disparity in infant mortality rates in the United States, and that we would hope that this line would go from the upper left to the lower right, but it's actually going from the lower left to the upper right, which is not the direction that we want it to go in. We saw declines during the 40s, during World War II, when we came together as a country, this whole idea of social cohesion, where we worked collectively on a whole lot of things. It really dropped fairly rapidly during that time. Also during the 1960s, when we had the war on poverty, where we made a concerted effort to address disparities and community engagement and health in all policies, we had a dramatic change. But since that time, we've really started to go up, and that's about the same time that our infant mortality rates, compared to the rest of the country, or the rest of the world, also started to decline. On the other end of the spectrum, this is life expectancy, which I talked about earlier, but you can see this is where, looking at U.S. males and females compared to the OECD males and females, the U.S. is in blue for both on the upper lines for females, lower lines for males. And again, we were tracking pretty much with the rest of the OECD countries, and in fact, for females, we're above other developed countries until around 1980, when we started to plateau and fall behind others in the developed world. So our ranks started to decline. And you can see that's also about the time in 1980 when the African American life expectancy rate compared to whites really started to also decline, where our disparities started to increase. Again, so I don't think it's coincidental that when our disparities started to increase, our improvements relative to the rest of the world also started to decrease. And I don't have a similar slide in terms of sort of the trajectory of maternal mortality rates, but this is one that you can see that the United States on the left is one of very few countries that has had an increase in maternal mortality rates over the last several years. We now have the highest maternal mortality rate among developed countries. And again, most of the disparities, most of the reason for this rise in maternal mortality is because of the disparities that we have between people of color and American Indians and the Caucasian races in the United States. So again, this is of great concern. And it's not because we've not been spending enough money. I think you can see in this slide, which shows along the x-axis the amount of money we spend per person per year on healthcare, and on the y-axis life expectancy. And the red line is the United States from year to year from 1970 to 2014. And you can see that we've been increasingly spending more and more money on healthcare. But compared to the gray lines, which are the other OECD countries, you can see that our life expectancy has really fallen behind. So actually it looks like the more money we spend, the farther behind we fall other countries in terms of life expectancy. So I argue this is, you know, as The Tale of Two Cities said they're the best of times and the worst of times. Well, this is the best of times for healthcare because we're doing a lot of investment in them, but it's the worst of times for health. And it's not because that we're spending overall on health. It's more because we're spending too much on medical care. This slide, which I'm hoping many of you have seen in other venues, shows the total health and human services spending from industrialized countries and breaks it out in terms of medical care spending and public health and social service spending. And the blue lines are parts of bars are with the medical expenses, and the green lines are the public health and social service spending, human services spending. And you can see totally that the United States is not spending more than other countries on total health and human services spending. But what's unique is that the United States spends way over half of their total health and human services spending on medical care. This is markedly different than any other of the OECD countries. So for every dollar that the United States spends on healthcare, we spend about 55 cents on social services. Whereas in OECD countries, for every dollar they spend on health care, they spend about $2 on social services. And the more we learn about what actually creates health, it's those public health and social services that really have the biggest impact on overall population health. And the bottom part of this graph just shows the distribution of our healthcare resources. We spend 95 to 98% of our total healthcare dollars on medical care and very little on public health. And so why is this happening, and why did we get into this situation? Why are we spending so much on medical care, and why are we falling behind the rest of the industrialized world on the indicators that most people use, maternal mortality, infant mortality, and longevity? And I think it really revolves around the fact that our policies and our programs evolve from our worldview of how we create health, how the world functions. And our worldview is really this, outlined in this slide. It's really about bootstraps individualism. You know, the rugged individualist, pull yourselves up. If you work hard enough, you will do well. You know, that allows or aligns with the whole idea of the virtue of work. About free market, if we just had competition, we would be able to solve all of our problems. Government's role is very small. In the last presidential election, you heard people say, we should just make government go away. Education is for job training. Certainly those of you in academia get a sense of this mistrust of science, our reliance on technology and specialization, and that structural discrimination is a thing of the past. We dealt with that late in 1964 and 65 with the Civil Rights Act and the Voting Rights Act. Let's get over it, move on. That's just structural discrimination is a thing of the past. And so what that has done is really led to a decreased investment in the commons or the public good, and decreased investment in the disadvantaged. If people just worked hard enough, they would do well. So let's not, encourage them not to work for pay. It increases competition. The whole idea of free market solutions. We don't mind winners and losers, but in health, that's really not a good model. It increases polarization, and it leads to an overinvestment in our biomedical model, as you can see from our investments since the 1980s, where we started to move away from the rest of the industrialized world in terms of our investment in healthcare, this overinvestment into the biomedical model. And one of the ways that we have tried to address that is say, well, let's improve healthcare. So that's where the triple aim of healthcare came about. We really are not making good use of the dollars that we invest. We're not getting good payback. So let's really focus on improving care for individuals. Let's lower per capita costs, and let's hope that then that has better health for our populations overall. And I argue that the triple aim of healthcare by itself is really not beneficial to health. It has not moved us to better health or health equity, and properly by itself could be detrimental to health because it's an individual health model. It is not a community health model. And what's good for health care may not necessarily be what's best for communities or certainly for advancing health equity. As I look at our investments in primary care, which is one of the things, part of our healthcare system that actually can improve health and can reduce costs. We're not investing in primary care. We're investing in specialty care. Out of the $10,000 per person per year that we're investing in healthcare, less than 300 of those dollars are going into primary care. So obviously what's good for health care is not good for health. And the triple aim of health care really enforces the narrative about what creates health. It's all about health care. That's what creates health. And it makes health care the benevolent dictator of health. If we talk about, how are we going to improve health? Well, let's look to the healthcare sector for that. That's why all of the discussions about the ACA and the replacing ACA has all been about insurance and access to care, with people not recognizing that a big part of the ACA is about public health and things that really do create health. It has not even been part of the conversation. The narrative has all been about access to clinical care and health insurance. And so this slide is really what, given all of that background, that's what I had in mind when I became health commissioner in 2011, which is the end part of this slide. And I use this slide because it points out the fact that we need to change how we do our work. This is the BlackWhite Difference in infant mortality rates in the United States. And I got into public health in 1980, running the maternal and child health program for the city of Minneapolis, for the Minneapolis Health Department. And infant mortality was the issue that really was primary in my job as the director of maternal and child health. That's what I got into public health to address. And so for 15 years running that program, we worked on infant mortality and particularly on disparities. And I brought all of the best medical care that I did from the 2 residencies that I did in internal medicine and pediatrics, and all of that training, and all of the good public health work that I had gotten from my master's in public health and my work in communities. And for 15 years, got people enrolled in Medicaid, got them enrolled in WIC, regionalized perinatal care services, did a whole variety of medical care activities with community-oriented primary care, and all of the public health services that we did with education and WIC and all of those things for 15 years, and thought we did a really good job. And then I left to run the health service at the University of Minnesota for 16 years, and then came back into governmental public health in 2011 and looked back at those 31 years that had transpired since I started in maternal and child health in 1980 to see what had happened. And it really shocked me and actually angered me to see that the African American infant mortality rate in 2011 still had not reached the white infant mortality rate in 1980. In 31 years, with all of the best medical care and all of the best public health that we could muster, we still had not closed that gap to a level that really was sufficient. So it told me that we really needed to change how we did our work. And because the opportunity to be healthy is not equally available everywhere for everyone. The huge disparities are certainly something that I think we need to focus on certainly us as a state here in Minnesota, but I think as a country. And that's why I really focused on equity as part of the focus that I take in our state, and then as ASCO president last year, focusing on equity. And it really revolved from this, the Jeffrey Vickers quote, that the landmarks of political, economic, and social history are the moments when some condition passed from the category of the given into the category of the intolerable. Public health might be the record of successive redefinings of the unacceptable. And there are so many things, and it's just a given that African American and American Indian babies are going to die at 2.5 times that of their white counterparts. That's just a given. We just assume that's going to be the way it is. Why is that not intolerable? Or the fact that African American adolescent males get incarcerated at 10 times the rate of white adolescent males. Why is that a given? Why is that not intolerable? And why that we spend 95% of our total health care investment in treatment and less than 5% on prevention? Why is that a given? Why is that not intolerable? So that's our job, is to redefine those and move things from the given category into the intolerable category. And I think that's what I'm trying to do with the work that I do and the bully pulpit that I have as health commissioner. And then it revolves back to the more classic definition of public health, what we as a society do collectively to assure the conditions in which people can be healthy, and particularly at which all people can be healthy, to make sure that health is not about averages. It's about that opportunity for everybody to be healthy. And this really focuses on conditions in which people can be healthy. And that's what we know from a lot of our work, that it's living conditions that really have the biggest impact on health. You know as well as I from all of the data that's coming out that where you live makes a difference in your health. You know, I'm fortunate to live in a community of opportunity where I have a stable house, thriving businesses, I can walk to grocery stores, I have parks and trails, I have good IT connectivity, strong local governance. When I call the police, they will come and they will treat me with respect. But also there are, in our community, many low opportunity communities where housing is unstable, foreclosures are rampant. We have lots of liquor stores and food deserts and poor IT connectivity, and the schools are not good. And when they call the police, they're not sure that they will respond, or if they do respond, they may be, or how they will be treated. That by itself, just living in those neighborhoods, of an opportunity neighborhood or a low opportunity neighborhood, has an impact on your health status. So it's not surprising that we see differences just based on living conditions. And I'm sure many of you have, in your cities where you are, have seen these RWJF maps. This is one for Minneapolis, St. Paul, but it's no different than Washington, D.C. or Dallas or New Orleans or St. Louis. It's all the same. Within just a few miles, you have huge discrepancy in life expectancy based on the living conditions in those areas. And those conditions, you know, as you're aware, are called the social determinants of health, the conditions which impact the health of people where they live and grow and work and age, that impact their health but are beyond their individual control. They're shaped by the distribution of money and power and social policies and politics. And those are the conditions that really impact health. And so we know that. We know that living conditions impact health. But we also know that some populations, particularly low-income populations and populations of color and American Indians, have a difficult time impacting those living conditions. And certainly I know from working in the field of public health for over 40 years that those of us in public health have few skills in how to change those living conditions. And that's where I think our work has to be. We need to start focusing on that capacity to act. How do we create the capacity to act? How do we build the power to change living conditions, which we know then will improve health? And so it is that focus on how to change the living conditions that has been the focus of the work that we've been doing here in Minnesota and the work that I've been trying to do with my colleagues throughout the country. And we're doing this by having this theory of change, that we need to organize the narrative, the resources, and the people. That's the theory of change. We need to organize the narrative so that we can align how people talk about health, how they think about health, in order to build a public understanding and the public will to make change. We need to organize the resources so that we can invest in the right things and we can change the systems and the processes that are attached to those. And we need to organize people so they get engaged in policy-making decisions and holding people accountable, the elected officials accountable, and being at the table to represent their communities. So this is our theory of change, and using that theory of change, we put together the triple aim of health equity to balance off the triple aim of health care. And it really is, and I'll go through this, the triple aim of health equity is, first of all, to expand our understanding of what creates health, implement a health in all policies approach with health equity as the goal, and strengthen the capacity of communities to create their own healthy future. And it's all built around the idea of social cohesion, that we're in this collectively, that health is not an individual thing, that it actually, health is created in communities, it's created in families, it's created in relationships, and a focus on social cohesion is what's necessary to move us forward. And then, so let's talk about expanding our understanding about what creates health. Narrative is really important, and Abraham Lincoln identified this, you know, over 100 years ago. He talked about public sentiment, but that's really about narrative. He said public sentiment is everything. With public sentiment, nothing can fail. Without it, nothing can succeed. Consequently, he who molds public sentiment goes deeper than he who enacts statutes or pronounces decision. He who molds public sentiment makes statutes and decisions possible or impossible to be executed. So we need to really talk about narrative. And that's what I do as health commissioner in the bully pulpit that I have. I think the thing that I do mostly is try to change the narrative about what creates health. And the common narrative right now, based on that worldview that I showed you earlier, is that people would be healthy if they just worked hard, made good choices about diet and physical activity and substances, and had good medical care. In other words, health is your individual responsibility until you get sick, and then it becomes the responsibility of the healthcare system. That's the common narrative. But we know from the data that that is not what creates health. It's not about medical care and personal choices. Yes, they are important, but they are not the major determinants. Certainly this slide from Tarlov et al. Is similar to what McGinnis and Faggy did, but they added genes and biology because what we're knowing about epigenetics and newborn screening and things like that, I think genes and biology have to be in there. But clinical care is really only about 10%, and health behaviors, excuse me, are about 30%. It's really about the socioeconomic factors. And those and those socioeconomic factors are the things that the World Health Organization has listed on the right-hand side of this slide in black. Since that's been put together, I added in blue some of the other things. IT connectivity, I think that is a social determinant. Mobility, I think healthcare by itself is a social determinant because it's beyond the control of the individual. And then social responsibility, how we market things, how we hold businesses in particular are accountable for how they market, is a socially responsible thing that is beyond the control of the individual. And so socioeconomic factors are really important in terms of what really creates health. And let's look a little bit at the behaviors, that 30% of behaviors. And behaviors really are about how people use tobacco and alcohol and their physical activity level and their diet. And you can see these attributable causes of death. But when you really factor in the slide I had showed earlier about living conditions, if you live in one of those low opportunity communities, how possible is it for you to make healthy choices about diet and physical activity? And then given the fact that in the United States each year, $15 billion is spent on tobacco marketing, and $6 billion spent on marketing alcohol, and $3 billion is spent just by one soda company on marketing their product, and that we spend $1.8 billion, most of that on unhealthy food marketing, and only 50 million of that 1.8 billion on healthy food marketing. It's hard to make a healthy choice when the healthy choice is being overwhelmed by marketing and by the fact that the healthy choice is really not, in some cases, a possible choice. So I argue that we're not trying to make the healthy choice the easy choice. First of all, we need to make the healthy choice a possible choice. And so given all of that, this is, I don't have any data to back this up. This is just my personal belief that, health behaviors, as important as they are, and we need to hold people accountable for their decisions, it's really the socioeconomic factors that overwhelm all else in terms of what creates health. Probably 60 to 75% of our health is determined by the socioeconomic factors, the social determinants of health. And those determinants are created and enhanced by policies and systems that really impact our physical and social environment. And likewise, the disparities are not because of lack of access to medical care and personal choices. They're really the result of those policy decisions that systematically disadvantage some populations over others, particularly populations of color, American Indians, GLBT population, immigrants, refugees. And behind a lot of that is the structural racism that is behind a lot of those policies and systems. Not necessarily personal racism, that's another topic altogether, but structural racism. And it's not about intention, it's about outcome and results. So for example, we looked at our own policies within our health department, our granting policies. How do we do grants to community agencies when we really require that any agency getting grants from our agency has all of the financial situations in place to make sure there's no fraud or abuse, that they can meet all of our requirements? It structurally disadvantages small organizations, new organizations, particularly organizations put together by immigrants where English is a second language. That's structural discrimination. Or by the fact that we, in the past, we no longer do it, targeted our outreach for radon to homeowners, not recognizing that 75% of whites in our state are homeowners and only 21% of African Americans are homeowners. That's structural racism, that's structural discrimination. And so we're looking at our policies to see, inadvertently, they're disadvantaging some populations. So there's a lot of that behind. And then there's some even more blatant examples in terms of mortgages and redlining in communities that really were about structural racism. So what we're trying to do is say we need to expand our understanding about creates health, that it's not just about medical care and personal choices, but it's really about the socioeconomic factors. And so we challenge the dominant worldview. I think it's neither right or, I think worldviews are neither right or wrong, but we have to put together an alternative worldview, one that, that we need to think about in terms of interdependence and social cohesion. And yes, the virtue of work, but not necessarily work for pay, which is part of the dominant worldview, which was really highlighted in Clinton's welfare reform about getting people back to work. The virtue of work, yes, paid work is important, but so is parenting as important work, and volunteering and all sorts of other kinds of things, and mentoring that is the work that really adds to value to our society. Social responsibility and social justice is important as free market activities. Yes, I'm biased because I work in a governmental agency, but there is a role for government, particularly protecting the public good. Education is for enlightenment. Cooperation is important. We need generalists, and certainly equity is a challenge for us in the present, and particularly our work around historical trauma, which people want to forget about, but really we're seeing in our state in a whole variety of ways, historical trauma is really important to health. And so this alternative worldview is articulated by Wendell Berry. He said, we have lived by the assumption that what was good for us would be good for the world. We have been wrong. We must change our lives so that it will be possible to live by the contrary assumption that what is good for the world will be good for us. So the second part of the triple aim of health equity is implement health in all policies with health equity as the goal. And you know from where you live that your quality of life is really impacted by the schools and recreation and public transport and the quality of environment and the justice system and economic opportunity and good food. All of those sectors have to be functioning well and actually focusing on your overall health and well-being to make health be something that we achieve. And that's why we have this work that we're doing here is really working with all of our partners in those sectors to really focus on their impact on health. That's why we've been working on minimum wage. We've increased the minimum wage in Minnesota, and I believe that's probably the greatest public health achievement from the Dayton administration. You know that if you can move somebody from the lowest quintile of income to the second lowest quintile of income, just basically moving a family of 4 above $35,000 per year, you increase life expectancy by 3.5 years. Paid leave, paid parental leave decreases in 10 weeks of paid parental leave, decreases infant mortality by 10%. That's a health issue. So criminal justice, energy, transportation, marriage equity, buffer strips, all of those things we're working on. And it highlights also the fact that we have to have health equity as the goal. So paid leave, for example, if only full-time employees with high-paying jobs get paid leave and part-time workers and low-paid workers don't get paid leave, it actually enhances disparities. It doesn't reduce disparities. Or if transportation, which is certainly a health in all policies area, doesn't focus on equity, it can lead to gentrification of neighborhoods. So we really have to have health equity as the goal. And this really reflects that this health equity or health in all policies really springs from the World Health Organization framework on their social determinants of health. And I hope that many of you have seen this and then actually work with us, and we're doing a lot of work around this, and we're doing a lot of this with early childhood and child abuse and child safety, working with CDC in particular. But the focus of this on the right side is really that individual and their individual well-being and the material circumstances and their behaviors and their psychosocial factors. That's where a lot of the emphasis has been in our society. And that's where the health system really needs to work, where the health care can really do its work. Argue that the health care providers need to treat individuals in the context of their community. They need to work on the fact that if housing is unstable and if food security is an issue and their behavior activities related to the community and economics, the healthcare system needs to take those into account as they're dealing with those in that individual and the family. But what our job is as public health workers is actually to change the living conditions, work on governance and social policy and public policies and cultural values that impact social class and impact racism, impact education, occupation, and income so that we can change the living conditions. So healthcare works on focusing on individual in the context of their community. Our job is to change the community for the better. And again, all around social cohesion and social capital. And one thing that we need to place into this framework that is coming out is climate change. I think that is one of those social determinants that really also has to be involved, because that also has huge equity issues in our communities. And so the third part is strengthen the capacity of communities to create their own healthy future. I mean, I'm sure all of you are familiar with this sort of scheme where, you know, we have people on the right-hand side of this who are afflicted with something, and we want to keep them from dying. So our specialty care and tertiary prevention come in. We want to rehabilitate them from this. This is where a lot of our resources go. Just to the left of that are people who have something, but they haven't been symptomatic yet. So that's where our secondary prevention comes in, looking at screening, early identification. That's where primary care comes in, the treating people to keep them from getting sick with whatever they're afflicted with. And then public health traditionally focuses on that vulnerable population, people who are at risk for something, which our primary prevention comes in. And so this is where, you know, we've spent most of our time and most of our money managing risks and diseases. That's where our health education and our screening tests and disease management and all of our clinical services come in. But the problem is that the vulnerable population is increasing, and it's sort of overwhelming. It'll be overwhelming the right side of the slide. So what we really need to do is focus on building safer and healthier populations. The work of transforming deprivation and dependency and violence and disconnection by strengthening democracy and accountability and leadership and community engagement. This is where our work in public health has to be, is building community capacity to create their own healthy futures. Like I said, this is building democracy. If people own the issues and are engaged and are at the table helping to make decisions and holding people accountable, things get done. We have seen this in our state where communities take on an issue and are organized, they can actually change policies. We had a light rail that was being built between Minneapolis and St. Paul, and the criteria from the Department of Transportation was how fast can you move people from one end of the line to the other. The people in the middle of that line in the central neighborhood were mostly low income, and people of color actually organized to say not having stops in our neighborhood actually is going to impact our health, it's going to impact our economy, it's going to impact our education of our children. And so they organized and actually got the Department of Transportation at the national level to change their criteria to have a community impact statement on those transportation things. Community got organized, changed policy, and actually is improving their health. So I, again, reflect on Wendell Berry. He said the community, in the fullest sense, is the smallest unit of health. To speak of the health of an isolated individual is a contradiction in terms. So I argue that we don't want to have patient-centered care. We want to have community-centered care, because individual cannot be healthy outside of communities. And so as Wendell Berry said, a proper community is a commonwealth, a place, a resource, an economy. It answers the needs, practical as well as social and spiritual, of its members, among them the need to need one another. The answer to the present alignment of political power with wealth is the restoration of the identity of community and the economy in that community. So we put together a set of questions around those three parts of the triple aim of health equity: expand our understanding. You know, what values do you bring to the table? What values underlie it? What are the health implications of the policies? Who's benefiting? Who's left out? And supporting community capacity. Who's at the decision-making table? Who's got power at the table? Who's held accountable? And so the bottom line is, what would it look like if equity was the starting point for all decision-making, which we're asking everybody in our agency to do, and I'm asking all of the other health departments and all people that I talk with. Let's put equity as a starting point. What would it look like? Our work would be different. Our work would be markedly different. It would really revolve around the triple aim of health equity. It would expand our understanding about what creates health, implement a health in all policies approach, and strengthen community capacities. These are the simple rules for dealing with complex situations, complex, wicked problems. But also, so you say, all right, this is fairly radical from this health commissioner in a blue state in the north central part of our country. But actually, it's going back to our roots. This is not brand new stuff. This is what public health has been about. Certainly those of you who are physicians on this call, when we became physicians, we did a Hippocratic Oath where we swore by Apollo the healer, Asclepius, the god of medicine, Hygeia, the goddess of public health, and Panacea, the goddess of well-being, as part of our oath. medical care, public health, and social well-being were part of our oath. If you look at, you know, those 50 most influential physicians, most of them dealt with acute diseases, infectious diseases back in the 19th and early 20th century, but it wasn't because they were dealing with infectious diseases that made them important, but because they were working on the conditions, living conditions in which people could be healthy. Certainly Rudolf Virchow, one of those, he said medicine is a social science and politics is nothing else but medicine on a large scale. Physicians are the natural attorneys of the poor and social problems should be solved by them. Also John Snow, you know, the father of epidemiology, he changed our understanding of what creates health. It's not necessarily something in the air, it's actually in the water and it's affected by living conditions. Reverend Henry Whitehead was able to get John Snow into the community to work with people to identify the prime source, and Joseph Bazalgette, the civil engineer, actually was the person who got rid of cholera. It was not the pump handle, it was Joseph Bazalgette creating a sewage system for London. It was a health and all policies approach, building community capacity. Landgrant Institutions, of which many of you are part of, were created to address changing economic conditions and social class. They were created in 1862, and that challenge is just as important today about changing economic and social classes in this country. It is part of our economic and our educational system. Certainly, as a pediatrician and the Children's Bureau, as I worked in maternal and child health, back in the 1910s when the Children's Bureau was started in the Department of Labor, work for infant welfare is more than philanthropy. It is a public concern which tests the public spirit of the democracy of a community. Justice for all children is a high ideal of democracy. Women's right to vote, which I believe, women's suffrage is, I believe, the biggest public health achievement of the 20th century, was really triple aim of health equity in action, engaging all members of a community, expanding a conversation about community, what creates health, and getting all sectors of society engaged in creating conditions for health. And Abraham Flexner, who changed medical care, who oftentimes gets a bad rap for that, but really said the physician's function is fast becoming social and preventative rather than individual and curative. Disease has been found to depend on large unpropitious environments, and these are matter for social regulation, and doctors have the duty to promote social regulations. And those of you in public health certainly know of the CEA Winslow, the Dean of the School of Public Health at Yale, and his classic definition, public health, preventing disease, prolonging life, promoting health, through the things that you identify classically, but it was an organized community effort for sanitation, community full of diseases, education, nursing service, but also the development of the social machinery to ensure everybody a standard of living and organizing these benefits to enable every citizen the birthright of health and longevity. Public health was about community organizing, about social conditions of health, social determinants of health. And then most recently, the war on poverty in the early 1960s. This was the 89th Congress. Can you imagine today's Congress passing these kinds of bills? This was a health and all policies approach. It expanded our understanding of what creates health, and it certainly built community capacity and was very successful in actually reducing disparities and improving health. And we can go into more detail on that. But finally, you know, it comes back to our core philosophy of public health. As Bill Foege from CDC said, the philosophy behind science is to discover truth. The philosophy behind medicine is to use truth for the benefit of your patient. And the philosophy behind public health is social justice. So that the work that public health does is make sure that everybody has their basic needs met and nobody benefits at the expense of somebody else, which is really my definition of public health. And so, or my definition of social justice. So this is the anniversary of Abe Lincoln being renominated for the presidency of the Republican Party in 1864. And in his acceptance speech, he said, "I have not permitted myself, gentlemen, to conclude that I am the best man in the country, but I am reminded in this connection of a story of an old Dutch farmer who remarked to a companion once that it was not best to swap horses when crossing streams." I argue that what really changed our trajectory in terms of life expectancy in this country was when medical care, clinical care, and public health went in opposite directions. We were very successful in the early part of this country. That's why I mentioned those physicians who worked on social conditions, working on infectious diseases. They were part of the public health infrastructure. Clinical medicine and public health worked hand in glove in the first part of the 20th century. In the latter part, the specialization took them in different directions. And that's why I believe that our improvement has changed, has slowed, and why our disparities have increased. And that's why we're not as healthy as we should be. And so I think bringing us back together, where we have medicine and public health working collaboratively around the whole idea of the triple aim of health equity, is really what's going to make us healthy. And so, because public health is what we do collectively to assure the conditions in which all people can be healthy, focus on those conditions. As my former senator from Minnesota said, we all do better when we all do better. We're in this together, and I'm interested in your comments and your questions, and so I open it up to the floor.
Wonderful. Thank you so much, Dr. Ehlinger. I want to remind everyone that you can submit your questions via the question box, and we will address them now. Looks like we have several questions. And the first one, considering that the work of public health is so vast and our work to address, we're working to address so many wicked problems, is there an elevator speech for the value of public health that you have, and can you share it?
Well, I think the elevator speech is from the definition of the Institute of Medicine. That's what I get to people, is public health is not a place of employment. It is what we do collectively as a society to assure the conditions. And so I argue to everybody in the elevator, you're a public health person if you really focus on improving the living conditions. You have a professional role and you have a civic role. And whatever your profession is, do that to the best of your ability with a focus on equity. But then in the civic role, bring that out to the conversations in school boards, in park boards, in water service districts, in soccer clubs, and PTAs, that all of us have a role to play in improving health, that it is not just the role of governmental public health.
Wonderful. Thank you. And then the next question, how can we get public health more front and center in political conversations? We don't do a good job of putting ourselves out there. Do you have any recommendations?
I think it takes people to tell the truth. We're data driven, and our job is to say, this is what the data are telling us. This is what creates health. And what I've identified here today are we know the social conditions really impact health. So it is part of leadership. That's why I argue and I make the case to my fellow colleagues as state health officials, that is their job, is to change that narrative, to create the narrative about what creates health, so that policymakers will hear that. And part of what our job is also to build the community capacity. When I get the community, when the communities own an issue, they bring it to the legislature, and it's very, very powerful. We did a report on income and health, which pointed out the fact, which helped lead to the change of the minimum wage. It was the community that got organized to ask the legislature to ask us to do that report on income and health. The community also asked the legislature to ask us to do that, our white paper on paid leave and health. When the community gets organized and asks the policymakers to do something, then we as public health, official public health leaders, have a much stronger voice, that because we're in partnership with the communities that we serve.
Great. And to follow up on that, this person is a recent MPH graduate and wants to apply their skills to public health, but is finding that a lot of the public health agencies are looking to hire nurses. Do you have any advice for encouraging recent MPH grads to make the most impact, to make their way into governmental public health or other public health agencies to address these skills at the community level?
Well, there's this complex question, but there are two parts of that. One is you can be a public health worker in places other than governmental public health. I think that if you have somebody, if they're on a clinical side, if you're working in a clinical organization, you can actually start to do community-oriented primary care and actually be able to start working on conditions where the enrollees of that clinic actually work or live, and you can just help to change those conditions from the medical care side, the clinical care side. You can do the same thing if you're in an educational institution, or if you're in an insurance company, for crying out loud. You can actually take a public health perspective and help to change that job. People create jobs. The job description is, what brings you in, but most people I know in public health actually change the jobs to meet, what they think really needs to happen. So that's on the non-governmental side. On the governmental public health side, right now it is underfunded. And the reason a lot of public health agencies are hiring more clinicians, particularly like nurses, is because we get paid to do services. We don't get paid to do the health equity work, the community organizing work, the partnership developments. And that's why, we need to argue to change that. And that's what we're trying to do with, some of the work that we're doing with our policymakers here, to say we need to invest in this public health infrastructure, which is really about building those partnerships. But there's also a conversation that we need to have internally in public health. A lot of public health agencies are wanting to get out of clinical services, but I'm having second thoughts about that, because sometimes the clinical services actually allow us to get into a community and actually expand how clinical services are done, and actually can influence living conditions from a little different perspective. So it's a broader question that would take a lot more time to really delve into.
I wish we had more time to do so. It looks like we do have a time for a few more questions. Can you speak to what you were doing in Minnesota to integrate primary care and behavioral health services?
Certainly. We're really focusing a lot on healthcare homes and behavioral healthcare homes. So we're trying to expand we're trying to actually build a community-oriented primary care model that was really tried and been so successful in the 1960s, developing that community-oriented primary care with healthcare homes, behavioral health homes, where we have a multidisciplinary team that is actually focusing on all of those issues. We're also working on communities to really actually develop community resilience, to actually do the prevention aspects of mental health, so that we're doing it from both sides, both the treatment side and the prevention side.
Thank you. And you mentioned that increasing minimum wage is one of the great public achievements of the last century. If you could choose one or two other great public health achievements for the next 100 years or so, maybe not that long, but what do you anticipate them being, or what do you hope them to be, if you could only choose one or two?
Well, the one I'm working on right now is paid leave, paid sick leave, paid family leave. I think that is the low-hanging fruit right now. The data are really strong on the impact of paid sick leave. It helps a whole variety of health issues. It actually helps grow the economy. I also think that, so those are the two things we're working on. And the other is building community capacity, that third part of the triple aim, like building community capacity, changing how we relate to communities, and recognize community organizing as a very powerful public health tool. And I think once we understand that and know how to do that community engagement, it's going to change the work of public health to integrate what we've learned from the past, but take it into this 21st century context.
Dr. Ehlinger, thank you so much. Unfortunately, we are approaching the end of our time, and I want to be respectful of yours and everyone else's. I think I speak for a lot of people when I could say I could listen to you all day. So thank you so much. Although we've learned a lot, we have a lot of work to do. So thank you for all you do, and thank you for taking the time today to speak with us. I want to mention this webinar has been recorded, and it will be available on the ASPPH website in the next 48 hours or so. You will all receive an email when that has been posted. And there are a few other webinars coming up in the ASPPH Presents webinar series. Please check them out, and don't hesitate to register. Thank you all, and have a great rest of your afternoon. Thank you, Dr. Ehlinger.